pathology resident in Hospital Universitario de Donostia in San Sebastián. I have an interesting case and I hope you enjoy it.
This is a 8 years old girl with history of congenital myotonia, and she came to the hospital for abdominal pain. And on a physical examination, mass was found on the iliac region, and the ultrasound showed solid mass with retroperitoneal extension. Now, in the MR, we can see two lesions. So the first lesion is a solid mass of 7 centimeters, so right here in the left anexa, and the second is a nodular mass of 2 centimeters below the ileum, the renal ileum, right here. Now, so the first lesion corresponding with the left ovary, and we observe that the normal parenchyma is replaced by a lesion with a trabecular pattern and sounds like sheets, so right here with some calcifications. And in this slide, we observe tumor nets that surrounded by fibrovascular tracts, so right here with some lymphocytes inside, and the tumoral cells have a polygonal appearance with a round hyperchromatic nucleus. So the second lesion corresponding lymphatic node, so right here, but there are minimal lymphatic node parenchyma because the rest is all a lesion. It's with the similar pattern and similar cellularity. Now, and in the same surgical act, a biopsy of the contralateral ovary was taken, and so that showed same pattern and same cellularity. So like here. And now, what do we do? We approach, this case has an ovarian tumor, and the differential diagnosis are also the possibility are a clear cell carcinoma or germ cells tumors like yolk sac tumor, embryonal carcinoma, dysgerminoma, teratoma, or choriocarcinoma, or the possibility of the sex cord stromal tumor. Now, we start the study with a cytokeratin that is negative, but with a dot-like stain, we can see here. So, in this point, it's not possible to clear cell carcinoma. Now we continue with the stains, and SAL4, that in this case is positive, it's a staining with a high sensibility for germinal tumors and open the possibility for this. So OCT4, and in this case is nuclear, is positive, and open the possibility between dysgerminoma and embryonal carcinoma and rule out the possibility of the yolk sac tumor and choriocarcinoma. And in this point, we think in these two entities and c-KIT that is staining with a high sensibility and specificity for the dysgerminoma, that in this case is positive. So alpha-fetoprotein is negative, is not a choriocarcinoma. CD30 negative is not an embryonal carcinoma, and inhibin is negative and is not a sex stromal tumor. So in the results, it's the possibility, it's the diagnosis of dysgerminoma. And now we have here the diagnosis, but we have to remember and take into account two data. And it's this here is the calcifications and the bilateral lesion, because there is the possibility of facing of gonadoblastoma. And now it's possible. So there are evidence of the progression from gonadoblastoma to dysgerminoma, or in the 50%, the gonadoblastoma coexists with dysgerminoma. So we inform about the possibility of gonadoblastoma, And the patient was again taken to surgery. So this slide corresponds with the right ovary, and we can see the same net, the same relation right here, and so here it's the same cellularity, the same pattern, and the same nets, and some calcifications right here. But in this time was a positive for inhibin. So now, gonadoblastoma is almost exclusive of gonadal dysgenesia, and there are correlations with Sayre syndrome. We have to remember this. So, in summary, the ovary tumors, there are epithelial tumors like carcinoma. There are germ cells, the tumor from germ cells that like dysgerminoma, embryonal carcinoma, choriocarcinoma, Gel-Sac tumor, or teratoma. And gonadoblastoma, that is from germ cells and sex cord stromal. So a few words of gonadoblastoma. So germ cells, tumors, and elements of the sex cord stroma. So it's almost, but not just exclusive of gonadal dysgenesias. And don't forget the correlation between with the Sayre syndrome. And in the 80%, the female is a phenotype. And in the 50%, coexists with dysgerminoma, and the clinic is a amenorrhea, and the treatment is a surgery and chemotherapy with excellent prognosis. And the last slide is just a message, is a take-away message. So don't forget always the clinical pathological correlations. They perform a comprehensive sampling of the tumor, the association of dysgerminoma and gonadoblastoma, like this case, and the gonadoblastoma and gonadal dysgenesia is almost, but not totally exclusive of this. And thank you.